you very much for joining this side event entitled One Health AMR and WASH, Is the Apocalypse Coming? First of all, we'd like to thank our sponsors for allowing this event to happen. And without further ado, we'll get started. So, as we've already mentioned, this is a One Health AMR and WASH talk along the lines of Is the Apocalypse Coming? My name's Derek Cocker. I work with the DRUM Consortium, which stands for Drivers of Resistance in Uganda and Malawi. And I'll start this presentation and we'll kick off with a side event outline. So what we're going to do in the next hour and a quarter is the following. First of all, we're going to start with an interactive quiz and summary of the current evidence base, and that'll take around 25 to 30 minutes. And then after that, we're going to go into a panel discussion with some of our experts where you can ask questions to them, and we'll try to think about some of the focus around WASH and AMR. So they'll be asked the question, what are the key drivers of AMR in low-income country settings? And where should we focus future efforts to address this AMR transmission? If I could just state at this point that if you are coming into them, and is it possible if you could please put your microphones to mute? So because this is going to be an interactive quiz, and hopefully you're going to enjoy that, we're going to start with some of the tech issues. So first of all, we're going to use a polling system called Mentee Meter to ask you those questions. And we're going to go through setting that up with you now. So once we've set that up, we'll ask you a series of questions. You'll get about 10 seconds to make your choices. Hopefully it's fun and interactive. All the answers are anonymous and will be fed back to you after each question. So it really is good if you could just try to be involved. I think it will be really interesting. Unfortunately, we don't have any prizes for you. Without further ado, let's get this started. So what you should have on your screen now is the Mentee Meter passcode on the left and a QR code on the right. So if you're joining this session now, if you go to mentee.com using that link, and then you enter the following code, you should be able to start asking the questions. If you look at the QR code on the right and you have a mobile phone or another device, you should be able to point your device with the camera setting at that QR code, and that will link you to a polling system on Mentee Meter where we can kick off. So I'm going to leave this up on the screen for about a minute to allow you to try to get that up. If you try to put it in a tab in your browser, that would be one way of making it work. I will direct you to the questions as they arise. Well, also one of my colleagues is going to put the link to this in the chat box. So if there's any issues with you trying to join at a later date, or you accidentally log out, or new people join in, then we can go again to Mentee and start that process. If you have any technical questions at all, then please put that in the chat and we'll try to solve them if we can. All right, so hopefully you're able to get into mentee.com. And what we should start off with now is we're going to first of all, see if it works by looking at 3 test questions with you. So we're going to ask you a question about human stool, about antibiotic consumption, and about morbidity and mortality of AMR. So now if you go to your Mentee tab, you should see that the first question comes up, and that question is this. How much human poo is estimated to be produced worldwide every year? So that's how much human poo is estimated to be produced annually in the globe. Is it less than 1 billion kilogram, 1 to 500 billion kilograms, 500 to 1 trillion kilograms, or more than 1 trillion kilograms? So the results are coming in. You can see each other's results as they come in. Don't let other people necessarily guide you. So our question here is, how much human stool is estimated to produce worldwide every year? Okay, so that's about 10 seconds, and we've got a spread of results here. And the answer to this question is this. Around 500 billion to 1 trillion kilograms of human stool is produced every year. So there's a lot of poo out there. Okay, next test question. How much did human antibiotic consumption increase from 2000 to 2015? So that's how much did human antibiotic consumption increase from 2000 to 2015? Was it less than 10%, 10 to 50%, 50 to 100%, or more than 100%? So we'll give a few more seconds for people to suggest their answers. Okay, great. So thanks for answering. It's a bit of a spread again, and people are going for quite a large increase in antibiotic consumption, and you'd be right. So the actual answer to this question is between 50 to 100% increase in antibiotic consumption in humans from 2000 to 2015. So there's a lot of human stool and there's a lot of antibiotics used in humans. So our next and final test question is, how many people are currently estimated to die annually from antimicrobial causes? The answer to this one is from the 2014 O'Neill report. So is it less than 500,000, 500,000 to a million, more than a million, or we're unable to assess? So that's how many people are currently estimated to die every year from all AMR causes. Great, so people are getting the hang of this now and answering the question. I think this is a bit of a trick to answer, but I'm going to give you the answer from the O'Neill report, and this is the answer. So in our brackets here, the answer would fall between 500,000 and 1 million. I think it's fair to say that those of you that chose a million or unable to assess would also potentially be right if it was from other reports. And truly, with unable to assess is potentially one of the cases, considering antimicrobial resistance metrics are based on somewhat limited data. But great, so Mentee Meter's working, and we're starting to get some of those test questions done. So as we've described, there's a lot of human stool produced every year, about 110 billion kilograms. There's an increase in human antibiotic consumption at around 65% in 15 years, and around 700,000 people every year are estimated to die from antimicrobial resistance causes in terms of bacteria, virus, and protozoal effects. So a bit of background before we start the session. So what do we mean by One Health? Well, what we refer to by as One Health is where the nexus of animal health, human health, and environmental health are linked. And so when we're thinking about One Health perspectives and trying to solve problems, we think about communicating, coordinating, collaborating with specialists in the human, animal, and environmental health spheres to try to achieve the best outcome for all. So it's trying to look at things from perspectives that have not always been noted to be the areas of which they're most concerned. So why is AMR important? We know that there's a high annual number of human and animal deaths. We've already asked that question from the O'Neill report. But there are rising rates of AMR seen globally, and that there are increased projected deaths in the future. So we've probably all seen this report, 2014, which suggested that 10 million people would die from antimicrobial resistance by 2050 if things were not to change. And there are a few treatment options in particular settings to treat AMR. Limited novel antibiotics in the pipeline, so we're not creating new drugs, and there are large economic costs and burdens to AMR. So that's why AMR is important. It's a very broad topic, and for the purpose of the rest of this event, we're going to focus on gram-negative resistance because of the fecal oral acquisition. Why are we also looking at low-income countries or low to middle-income countries? Well, these are the places where there's the greatest burden of infectious diseases and rising rates of AMR seen. On the right is a paper from Patrick Masicha in Malawi, looking at trends of AMR between 1998 and 2016 from E. coli on the top and Klebsiella pneumoniae on the bottom, showing that in Enterobacteriaceae species, we see that there are rising rates of AMR in these settings. And these settings have the most limited resources available and often reduced access to antibiotics to treat the most severe infections. And as a result of that, there are high projected mortality from AMR in these particular settings in the future. So that's a bit of the background. And when we refer to this title, we refer to it as an apoocalypse. So why may the apoocalypse be nigh? Well, the world produces a lot of poo, around 4 trillion kilograms in total, 80% of which comes from livestock animals and 20% from humans. And almost all of that ends up in the broader environment. So we can see the One Health effects at play there. And a lot of that stool is poorly managed and harbours resistant bacteria such as ESBL bacteria or extended spectrum beta-lactamase. And this type of resistant bacteria is often mostly concentrated in low-income country settings. So one of the reports from David Brenders, as one of the people on our call, suggested that in low-income regions such as Africa, Southeast Asia, and the Western Pacific, around 63% of the total feces of the world is produced in these areas, but 90% of the feces containing ESBL E. coli comes from these areas, again showing that low-income countries are affected most severely. And this may only get worse as food consumption and the production of meat increases, the amount of animals and human stool increases. This fecal ratio may allow this amount of poo to increase and AMR burden to get greater. So the apocalypse may be on the horizon. And with every apocalypse, we need some horsemen. So our question is, who are the horsemen of the apocalypse going to be? What do we really mean by this? Do we mean the countries, international organizations, and climate change denialists that will cause AMR? Well, not exactly. We more particularly want to look at what are the horsemen of the apocalypse going to be. So what factors are going to be the most important to tackle in reducing the burden of AMR? And given the limited resources, which ones should we be highlighting to policymakers? And this will be our final interactive question on Mentee Meter. So while we're going through the rest of this presentation, if you could just bear that in mind, this will be our final question of the day. Okay, so what do we know about the role of WASH in AMR? Well, historically, we know that WASH hasn't always either been accounted for in the causal framework of transmission, weighted as important, or integrated into policy and national action plans. On the right is a paper from the Lancet in 2016 showing the relative contribution of factors as drivers of AMR on the y-axis and those factors on the x-axis, and you can see that WASH isn't specifically mentioned here. It does fall under categories such as environmental contamination and healthcare transmission, and for those areas we have low to moderate evidence base, again highlighting that we need to have more data to know about the role of WASH in AMR. But currently there is a better understanding of the causative components, and there's a broad discourse around what we should do to reduce the AMR transmission and considering it from a WASH perspective, just like today. So we're going to now use the WHO technical brief on WASH preventing infections and reducing the spread of antimicrobial resistance to ask a few more questions around some of the One Health aspects of AMR. So first of all, we'll look at some of the environmental exposures. So again, this is the WHO technical brief, which you can find the link for on the bottom right. And some of the key environmental exposures could include industrial waste from antimicrobial manufacturing industries, so where antibiotics and their metabolites are pumped into the effluent of the river system and then dispersed into the broader environment. The untreated hospital and community effluent, so in terms of antibiotics and fecal bacteria and genes in the presence of this. And community exposure in terms of drains and surface waters. And all of this leads to contaminated groundwater, including animals and the environment. And together, they can lead to contaminated food sources and fecal oral acquisition. So the environment poses quite a significant risk. Right, time for some more questions. So when we think about environmental exposures to AMR, let's go back to Mentee Meter. So if you go open your new tab, you should find your next question, and this is it. So what concentration of the antibiotic ciprofloxacin has been found downstream in rivers where there's been an antibiotic manufacturing plant upstream? Is it no antibiotic found because it's rapidly dispersed and metabolized? Is it low amounts but significant to select for horizontal gene transfer? Or is it higher amounts than those seen inside the blood of patients taking the drug? So we'll repeat the question. What concentration of antibiotic ciprofloxacin has been found downstream in rivers where there's been an antibiotic manufacturing plant upstream? Okay, great. So we're getting some answers in now. And it's a relatively even split. This is the answer. So quite substantially and importantly, we found higher amounts of ciprofloxacin in the river systems downstream of these manufacturing plants than actually in the blood of patients. So the concentrations downstream are very high. Next question. Which of these wastewater treatment sites expels the greatest overall load of antimicrobial compounds into the broader environment? So that's which of these wastewater sites expels the greatest overall load of antimicrobial compounds, that's antibiotics and their metabolites, into the broader environment? Is it community wastewater pathways or hospital wastewater pathways? Please answer now. Okay, interesting, and once again, an even spread. And I'll just highlight to you the answer here. And the answer is the community wastewater pathways. it's fair to say that hospital wastewater pathways expel the greatest concentration of these antibiotics and the antimicrobial compounds, but given the volume, that the wastewater treatment plants from the community expel the greatest overall load. Okay, so our third question. What percentage of the world's population is thought to consume food from plants irrigated by wastewater? Is it less than 1%, 1 to 4%, 5 to 9%, or more than 9%? So what percentage of the world population is thought to consume food from plants irrigated by wastewater? Answer now. And I think you can all see what's popping up on screen. So I'll just give you a few more seconds to answer. But yes, that's right. So for those of you that said that the greater than 9%, that is correct. So around 10% of the world's population is thought to consume food from plants irrigated by wastewater. Okay. So keep your Mentee open. We'll go back to the presentation. So we've shown already that in terms of the environment, that there's a lot of antibiotics from downstream manufacturing plants that, sorry, 1 second. That the healthcare facilities and community wastewater treatment plants are both important, and around 10% of the world's population is thought to consume food from plants irrigated by wastewater. So next, what are the animal drivers of AMR? Well, they're increasing in unregulated antimicrobial usage in animals and agriculture. So by that we mean livestock animals and fish stocks. And there are poor waste management around animal excreta. And this in turn leads to contaminated groundwater and affects the broader environment. So now let's answer 1 or 2 questions in relation to some of these animal drivers of AMR. So back to your Mentee. And the next question is this. Who do you think consumes the most antibiotics annually? Is it us humans? Is it agriculture? Or is it aquaculture? So, who do you think consumes the most antibiotics annually? Well, we can see that there's one trend happening here. I'll give you a few more seconds to answer. Okay. Perfect. Right. Well, the answer to this question is, as the majority have very well identified, that livestock animals consume the most antibiotics annually. And next, our animal question. How much do you think this antibiotic consumption is expected to rise in livestock animals from 2015 to 2030? So that's how much is antibiotic consumption expected to rise in livestock animals from 2015 to 2030? Is it up to 30%, between 30 and 60%, between 60 and 90%, or more than 90%? So we've already shown that agriculture consumes the most antibiotics, and how much is that going to rise? Please answer now. Okay, great. So the answer to this question does lie within the category chosen at around 30 to 60% increase. So what we've shown here in terms of animal drivers is that, first of all, if you look at the graph on your left, that this is from modeling work done, that if you look at the different colors, these are different species. So gray is for humans, and then cattle in green, chickens in yellow, and pigs in pink, with fish in blue. But actually, even between now and in 2030, it's estimated that human consumption is nowhere near what it is even in pigs alone, and on comparison with chickens. And if you add them all together, it's substantially higher. We should also note that while the amount of antibiotics used in fish production here seems low. In terms of biomass, it's the highest.
Yes.
And in terms of increasing, sorry, did someone say something? Okay. And in terms of rates of increase, that's increasing the most. And on the right, the answer from modelling studies suggests that if no action is taken between 2015 and 2030, that more than 50% of the antibiotics in terms of livestock will increase. Okay, great. So the next question is the household and community exposure routes. So this is again some of the more traditional WASH effects. So we know that there's unsafe water supply, inadequate household sanitation, alongside cohabitation with animals, and all of this leads to contact with fecal contaminated household surfaces. I think with no reason on me asking such an educated audience as to questions around this, but we all very much are aware that some of the numbers, so around 780 million people lacking basic drinking water service, 2 billion people not having basic sanitation facilities, and in low-income countries, around 75% of people not having access to hand washing facilities. So when we put some numbers onto some of these areas, we can see that the context of the household and community effects in terms of WASH probably likely to be very important. So when we're thinking about that, what data do we have for the household level WASH and AMR context? Well, there is actually very limited studies out there in LMICs in particular, looking at the household relatedness to WASH and AMR in the literature. It's not that there isn't any, there are some, and we'll put some of those into the chat function later. But we don't really have numbers to put onto some of the following questions, such as what are the household WASH and AMR risks? Or what is the effect of animal cohabitation, or the role of the broader environment, let alone some of the other more basic effects, such as what is the prevalence of AMR in the community, whether that be ESBL or CP or anything. So sometimes there's numbers needed on this data set. So we're now just going to give a couple of minutes to this study, which is the DRUM study, which tries to put some numbers onto these aspects. So numbers of the panelists are part of this study, which is again stands for Drivers of Resistance in Uganda and Malawi. And we focus on ESBL genes in the bacteria E. coli and Klebsiella, looking at it from the household and community's perspective, and trying to work out, broadly speaking, what are the drivers of AMR in those settings. So DRUM does focus on 5 main areas, of which I'm not going to talk about numbers 2, 3, 4, and 5, other than to mention that we do look at antibiotic usage metrics, evolutionary trajectories of resistance, economic effects of AMR, and policy effects of AMR. But really what we're doing going to present to you today is just broadly how we've looked at whether WASH and antibiotic usage affect or drive AMR at a household level. To do this, there was a study in Uganda and Malawi of around 400 households in the community setting of rural, urban, and peri-urban components within those countries. Households were separated into either intensive or sparse, with intensive households undergoing WASH observations, sparse households not undergoing WASH observations. And within those households, we followed them up at 3 to 4 time points over 6 months, and at each point, questionnaires were asked alongside microbiological sampling of around 20 samples per visit. And so on the right-hand side, you can see the sampling frame that was done at each of these households, which includes the human, animal, and environmental spheres. So we took samples from the stool of humans at the household level, stool from animals at the households that were co-located, alongside the water that they drank, both in terms of the source water, whether that be from a kiosk or a borehole or a tap, alongside household drinking water and stored water in the house. We took food samples from fruit and vegetables, alongside hand contact samples from the floor in which they came into contact with, or door handles, fridge handles, and chopping boards, so contact surfaces, alongside the clothes they wore. External to that, we took broader environmental samples from the river water and drains, and we looked for the presence of ESBL bacteria using chromogenic media. So some preliminary microbiology results from Malawi alone. So we're not presenting the Ugandan results, but we found that after 12,000 samples were taken from the various spheres, that actually what we reported was in urban, peri-urban, and rural settings that ESBL prevalence was very high. So ESBL prevalence is on the x-axis, and on the y-axis there's the sample types, which mimic the diagram you saw before. And broadly speaking, what we can see is this. There is a high prevalence of ESBL in the colonization of humans within the regions. There's a high levels of ESBL colonization within the animals that were co-located at the households. And there are very high levels of ESBL present in the riverine environment. So that's the drainage systems and the river water. And importantly, what we can note as well is that the urban systems have higher rates of ESBL than the peri-urban or rural settings. And lastly, you can see that ESBL is present in every aspect of the study. So in the food that they ate, in the water that they drank, and in the environment and flora at which they were in contact. So this resistance was everywhere to more or less extent. And now I'd like to just hand over to Kondwani Chidwenzano, who's one of our colleagues from Malawi, to look at some of the WASH methodologies to try to unpack why this might be so highly prevalent. Kondwani.
Thanks very much, Derek. So in terms of WASH evaluation, various methods were applied to understand the drivers of antimicrobial resistance from the WASH perspective. For instance, direct observations were conducted to identify WASH behaviors in the households. And this was followed by focus group discussions, in-depth interviews, and learners survey that were conducted to understand the behavioral determinants of the identified WASH practices. Next slide, please, Derek. And in terms of the findings, the study noted that domestic animals were commonly seen in the household surroundings, and they were kept inside the houses of people. So they live together with people, and mostly during the night, mostly for security reasons. Hence, they were in contact with kitchen utensils, including buckets for storing water. And all this increases the risk of contamination. And even during the day, the animals were found accessing utensils when they were being put on the ground. Access to toilet facilities was high in all the study locations, where most households had pit latrines, but most of the latrines were traditional pit latrines, which were prone to collapse during the rainy season. Despite having high coverage of pit latrines, the study identified that there were low coverage of hand washing facilities, and only a few households had hand washing facilities with soap. And observations identified that most of the community members washed their hands by dipping in a container, and this compromised the quality of hand washing. Next slide, please, Derek. In terms of access to safe water, the study participants accessed water through various means. For instance, in the urban, they mostly used public taps, while in the rural, they accessed safe water with the use of boreholes. And the study also noted that the household members did not manage animal waste properly, as they were regarded as not of high risk compared to human waste. The study through transit walks also noted that people were always in contact with standing water, especially in drains, mostly during the rainy season, and also they were in contact with the river water. For instance, they could use the river water maybe for washing clothes. So briefly, these are some of the key findings from the WASH perspective. Over to you, Derek.
Thanks very much, Kondwani. It's all very important. And I think it's also to say that this is one of a number of studies that's ongoing, and some of these results will be available soon. So what we need to go into is our last question for you before we start the panel debate. So our final question for you is going to be the question we asked about at the beginning, which is trying to decide, after listening to some of the things we've presented to today, where you feel the most important things are for us to consider in this apoocalypse. So what are the 4 horsemen of the apoocalypse going to be? So bringing this together, what factors do you think are going to be the most important to tackle to reduce the burden of AMR? And given the limitation in resources, which ones should you or should we be highlighting to policymakers? So that's going to be our final question. So if you go to your Mentee Meter now, I'll take you through this. Please, if you haven't joined Mentee Meter, you can still use this in the link. And because it's the last question, I will leave this question live for you to answer during the panel debate as well. So with every apoocalypse, there are 4 horsemen. So you only get to choose 4, I'm afraid, of the following 16 choices. We realize that ideally we would choose them all, but for today's discussion, we'd like you to choose the 4 you think are most important. And these have been taken from the WHO technical brief and categorized by area, and I'll go through them now. So remember, when you're choosing these 4, you can choose up to 4 of the 16. So in the gray, numbers 1, 2, and 3 are human-related drivers. So that's the misuse and overuse of antibiotics in hospital settings, number 1, or in community settings, number 2. And then there's inadequate access to vaccines and diagnostics and affordable medicines in humans, number 3. 4, 5, and 6 pertain to more WASH drivers. So number 4 is lack of access to clean water. Number 5 is lack of access to improved sanitation and hygiene. And number 6 is poor infection control and disease prevention in healthcare facilities. 7 and 8 are animal factors or animal drivers. Number 7 is the misuse and overuse of antibiotics in animals. 8 is inadequate access to vaccine diagnostics and medicines in animals. 9 is a plant and crop driver, misuse and overuse of antibiotics or biocides in the environment. 10, 11, and 12 pertain to environmental drivers, so the discharge of waste from healthcare facilities, 10, or the discharge of waste from pharmaceutical manufacturing industries, 11, or the discharge of waste and wastewater from farms and agriculture, 12. 13 is food and feed drivers, so poor infection control and disease prevention within the food chain. And 14 and 15 relate to more general measures such as inadequate national and international AMR surveillance systems, 14, and inadequate national and international policy and multi-sectoral coordination, 15. If you feel as though there's another factor which is not categorized in those first 15, you could choose 16. And ideally, if you could put something into the chat, that would be very useful. So you can choose any 4 of those 16 in the Mentee Meter now. Right. What are people starting to choose? I'll leave this slide, I'll close this slide for a second, but I'll let you continue to answer for another 20 to 30 seconds because it's a big question. Okay. Okay, I'll show you the results now. So interesting. So there's a big, broad measure. So obviously everything is very important, but the things that are currently standing out from people who have voted include human driver, such as the misuse and overuse of antibiotics in the community, WASH driver, so the lack of access to improved sanitation and hygiene, the animal driver, so the misuse and overuse of antibiotics in animals, and then I think pipping it just about is inadequate national and international AMR surveillance systems. So I'll keep this question live, and if you want, I'll give you the results of this in the chat box at the end. But thank you very much for the interactive component. That's all very interesting, and we'll continue to hand this over now to my colleague Tracy, who will start the panel discussion. Thank you very much.
Thanks very much, Derek. That was fantastic. And thanks to you and Convening for setting the scene for the side event. It's really exciting to be able to see some of the, and start sharing some of the initial findings of the DRUM consortium, especially the work across Malawi. And you're both so instrumental in all of that work. So it's great to see you being able to present it. We appreciate that people in the audience may have questions about some of the data that Derek and Convening presented. So if you are happy, please go and ask those in Pathable, and Convening and Derek will be very happy to answer them in Pathable in the chat. Equally, we can pose those to the panel as well. But in the interest of time, we want to try and move on to the panel at this point. So having set us up perfectly, we want to explore the question of what are the key drivers of AMR in low and middle income countries, and where should we really focus our future efforts in trying to address AMR transmission. There have already been so many fantastic presentations this week and discussions and panels and plenaries that have talked across the topics of environmental sanitation, environmental health, and have even touched upon the importance of AMR. And they've really looked at the wide range of structural and economic, institutional and behavioural influences on this potential apoocalypse, as Derek called it. And I'm looking forward to hearing our panel's thoughts on their Horsemen, as well as their thoughts on what you've chosen as well. In an attempt to get the prize for the most amount of people in a panel at UNC this year, we have a number of experts here to share their thoughts. And although we are many, we really wanted to make sure that we were reflecting that One Health element that Derek spoke about at the beginning, and keep the conversation as interdisciplinary as possible. So Derek, if you wouldn't mind stopping sharing there, and without further ado, I'll ask the panel members if they can please put their cameras on for now, to let me introduce them briefly. And it will be very brief because we want to listen to them talk and not me. Please feel free, panel members, to give a friendly wave when I introduce you. And I'm hoping that the spotlighting will work, or is working as well, for those of you watching. Okay, so first I'll introduce Nick Feasey. Nick is a professor of microbiology and infectious disease with Liverpool School of Tropical Medicine and the Malawi Liverpool Wellcome Trust. He's based in Malawi, and Nick comes from a clinical background, which he'll be sharing with us today, and is PI of the DRUM consortium that was mentioned in the earlier presentation. We've got Kate Medlicott, who is the Sanitation and Wastewater Team Lead at the World Health Organization. And there she's responsible for translating evidence to policy and practice, and very importantly, led the development of the guidance referred to by Derek earlier, and we'll be touching upon that. We're delighted to have Amy Pickering here as well, who's an assistant professor and the Blum Center Distinguished Chair in Global Poverty and Practice at UC Berkeley. Amy brings a fantastic range of experience and interdisciplinary perspectives to interrupting the disease transmission, particularly in low and middle income settings, that she'll be sharing today. And Andrew Singer, who's a senior scientist at the UK Centre for Ecology and Hydrology. So although originally hailing from the US, he is now based in the UK and focuses on applied research and understanding the effect of pollution on microbial ecology and ecosystem functions. I'm really delighted to welcome my colleague David Masoke, who's a lecturer in the Department of Disease Control and Environmental Health in the School of Public Health at Makerere University in Uganda. He works extensively across WASH and community-based health research in both Uganda and across sub-Saharan Africa, including working with us on the DRUM consortium. We have Joe Brown, who I hope has had a little bit of a chance to have a rest from the plenary that he was just in as well. Joe's, as you would have heard, is Associate Professor at the Department of Environmental Sciences and Engineering at UNC Gillings School of Global Public Health. And I hope he brings together the different experience from a significant portfolio of work across the WASH sector, both in low middle income settings and also high income settings that we've just been hearing about. David Berendez, who's epidemiologist at the Waterborne Disease Prevention branch of the CDC, and brings not only these skills to the discussions today, but also his experience from both SaniPath and in supporting the development and testing of low-cost systems for environmental monitoring of environmental AMR. And I'm going to just check, I don't think that we have our colleague Lawrence Mugisha, who we'd hoped would be here today, who is our Associate Professor from the College of Veterinary Medicine. So, oh, you're there, Lawrence. Yay, you made it. Yeah. That's great. Welcome, Lawrence. I'm glad. I was worried we wouldn't have the animal perspective. So great. Lawrence is at Makerere University as well, along with David. So will give us the animal perspective today. So I've got some questions to get us started with each of the panel members, but I would love to see your questions appear in Pathable. I will try as best I can to keep track of both the Zoom screen and the Pathable screen as well. So feel free to put them in there. But starting by looking at the wider policy and strategy perspective with you, Kate, if I may. So the technical brief that Derek mentioned from the WHO is a great asset to us all in looking at how we move forward with this and the wider context. So I wonder if you could talk a little around what evidence you think we need to collate and strengthen to best inform that wider AMR policy decisions that we're making in low middle income settings at the moment.
Yeah, certainly. Well, first, let me say thank you for that presentation, for making it kind of really simple and clear. It's difficult to communicate all of these dimensions, and I always love a title that can work per. So well done on that. To the question about policy, I think where the kind of rubber hits the road at the country level, it's in these national action plans. And, you know, they're a really multi-sectoral process. And if you look at all of the ones that have been done, unfortunately, even though kind of environment is increasingly recognised as an important part that should be there, there's typically not much in there on environment. It's not necessarily particularly strategic things, and the people who are involved in the development aren't necessarily from the WASH and wastewater sector. So we've got some work to do there, I think, on really getting the right people at the table and the right risk-based things within those national action plans. So in terms of the evidence we need, I think what we really need is like I say simple because I know, knowing it's not really that simple, but we need like a risk assessment tool that can say in any given context, looking at what's going on in the agricultural sector, what's going on in WASH access and agriculture, all of these things we just talked about, where are the kind of the big risk factors and hotspots, and what are some of the kind of more achievable things that could go into the action plan based on those risks. So I'd really love to see a tool like that we could then confidently justify what we're proposing goes into national action plans. And I think without it, what often happens is people will go, oh, well, is that really AMR? That's just kind of the development agenda. Why should it be here? And I think we haven't articulated clearly enough as well what's kind of AMR specific and what will make will help to address AMR, but also is important in our broader work on development and disease prevention. I'll stop there.
Thanks, Kate. And I think that raises the really important point that AMR in some way piggybacks, right, on all these other development issues that we need to address as well. Amy, if I could maybe come to you next and ask if you can maybe drill down a little bit more on what you think are the current gaps in evidence around the WASH or environmental sanitation side of things that we need to address around AMR, and perhaps what you would like to see coming out in studies in the not too distant future, I would hope, to address those gaps.
Sure, great. I mean, as an academic, we always want to do more studies, so I'm happy to talk about that. I would argue that there are two main evidence gaps. I think first, understanding the efficacy of non-centralized WASH infrastructure and services relevant for low and middle income countries at mitigating the discharge of antibiotic residues and resistance genes into the environment. And then second, evaluating the effect of relevant WASH interventions on the burden of antibiotic-resistant infections in humans and on antibiotic drug consumption in humans. So, of course, it's not easy to fill these evidence gaps, but it would be great to see health impact evaluations of WASH interventions start to include some AMR indicators, including both environmental sampling of AMR, such as wastewater-based and exposure pathways, but as well as measurements of human antibiotic drug consumption and gut colonization with AMR. So for example, trials that are already planning to collect stool samples for measurements of enteric pathogens and control and treatment groups, or even previous trials that have archived these samples could analyze them for resistant bacteria and resistance genes. Of course, it would also be nice if there were better objective and standardized methods for measuring antibiotic consumption in humans. Wouldn't it be nice to have an objective indicator in stool samples, for example, of antibiotic residues? And then I would say, finally, I just want to make a plug for Dr. Erica Vermeister's presentation later today in room 4 at 1:30 p.m. Eastern. And she's going to be presenting a global analysis that we've done of WASH access and the burden of AMR in the gut using georeferenced publicly available stool metagenomes. So tune in then to find out the evidence that we've gathered there.
Thanks, Amy. I always like a good plug for the next session, so that's good. I welcome more as we go through. I wonder then, before I maybe come and talk about Uganda specifically, because Amy, you've talked there about the importance of how we sample and how, having methods that we can try and standardize testing and standardize how we know what's going on in these different elements. If I could go to David Berendez, and David, maybe ask you a little bit more about the methods that you've been involved with there. I know with the CDC and how you see those kind of low cost or easier opportunities to use technologies that are more appropriate for low middle income settings.
Absolutely. I mean, I think it's not just us at CDC. I'll say, WHO has the tricycle method that's culture-based membrane filtration. we kind of tested alongside that in IDEX-based methods. At their core, both of those are water testing, and many have done as well wastewater testing based methods. So I completely agree with what Amy was talking about, that it's really about, and we can, adding on AR to existing systems that are already doing some of this testing, especially for us from a surveillance point. I think that we need to think about putting numbers on AR in the environment community settings, and really that starts with, building the capacity to do this basic kind of tier 1 laboratory testing that our environmental microbiology colleagues know how to do so well, and many labs can do, but adding in the AR component to it so that we can start to look what the differences look like over time and across sites, and not just say, as many of us have, and I'm guilty of this as well, hey, we found antibiotic resistance in the environment. That gets to Kate's so what question. Okay, so what are you going to do about it? You found it. What does that actually mean? So we need to know what the relative levels are and what that means. I think that, from a sampling perspective, it's really about, as you're doing in Drum Study and others, finding a medium of the environment or a compartment or two that most efficiently capture community surveillance, whether that's environmental waters or wastewater and fecal sludge. And environmental waters are kind of an appealing sink for everything, because they also, happen to be where a lot of gene transfer might occur anyways. We kind of have to remember that, bacteria are going to do what they want to do, and they've been doing this way before we came along, and they're going to continue to do it way after we're gone. So, it's really about disrupting the chance for them to transfer genes as much as we can. And then I think that the other aspect of sampling is really, as you're talking about One Health, is connecting that environment to food and human systems. So we have human systems for AR at the Ministries of Health. We have food systems off in the Ministry of Agriculture. We need the Ministry of Water to have environmental systems and have those connected so that, we're seeing the full picture together within these countries.
Thanks, David. You've made my choice of who to go to next quite challenging there with the points that you've raised. So that's always a good thing to do to me. I think because you touched so much upon the kind of idea of those environmental sinks, and as Derek showed in the presentation, that there was really high percentage of positivity when we're looking at riverine systems. I maybe go to you next, Andrew, because I know you have a lot of thoughts about the challenges of trying to measure the longitudinal and seasonal changes across these systems as well, and what role those riverine systems and wider environments are playing in AMR distribution.
Oh gosh, you just touched on something that I could probably speak to about hours. But I'll try to sum it up in the fact that really the biggest problem is what we've all just mentioned in the emoji. It's poo, and the stuff that's in the poo is generated by us or by an animal, and if that animal had or the human had antibiotics, you just get a lot more antibiotic resistance going into the environment. Primarily because we don't treat most of our sewage the way that we think we do, or we know we don't. So it's not really in the category of, even if we have sewage works, we're doing well. In fact, I noticed in the last slide that the last question, I don't want to start a scene here, but there were 3 environmental sewage related flows. One is discharge of waste from healthcare facilities. One is discharge of waste from pharmaceutical manufacturing. And the other was discharge of waste from wastewater from farms and agriculture. Well, I mean, the elephant in the room is that there's no human waste on that list. How the heck did that get missed? I don't know, because it was probably question number 2 in the quiz, that it's the biggest source of waste going out into the environment. So, I mean, the elephant in the room is that wastewater treatment, even at its best, is the biggest source of AMR going into the environment. And of course, if you don't have treatment, then, you're up shit's creek. So, quite literally, and that's where it's all coming from. And, we've talked about lots of ways that you can address it, but it's been, a problem for humanity for thousands of years. You can try to sort it out. One of the problems is if you build a sewage treatment plant, you've got to man it with someone who knows how to actually run it. There are lots of sewage treatment plants in the world where no one actually knows how to run it, and it's poo in, poo out. So it's a big problem, and there isn't a quick fix, but we do know how to fix it. It's just that we have to, set our mind to it.
And you've really unintentionally set me up perfectly there, Andrew, to move into who are the right people to kind of maybe try and address and manage that problem. And I can maybe go to the colleagues in Uganda now, and David Musoke. We also have two Davids on the panel, just to make things confusing as well. So David Musoke, I wonder if you want to kind of pick up on Andrew and David Berendez's comments there around the wider environment and perhaps the role of environmental health, where I know you're coming from that background, and what you think the role of WASH and environmental health is in trying to control that.
Thanks so much, Tracy. And I wouldn't agree more that indeed environmental health has a critical role to play in this whole discussion. And I just want to emphasize from the Ugandan experiences, the fact that a lot has been done and there's a lot of evidence that exists on WASH indicators, but there's actually not much we can attribute the WASH situation to AMR. And just to give some perspectives on the local situation, if you asked about our WASH status in Uganda, I can comfortably say that we have evidence concerning water coverage being about 7% nationally. Access to sanitation is about 80% in the rural and about 90% in the urban. If you talk about percentage of open defecation, statistics are very clear, about 20 in rural and about 10 in the urban. If you talk about percentage of the population with hand washing facilities, again, a lot of evidence is available, including this being around 40% in the rural and 60% in the urban. So this is just to give some insights in terms of the figures we have concerning the WASH situation in our developing countries. But if you asked me, okay, so if that is the case concerning the WASH indicators, how much of that is actually contributing to AMR? I wouldn't give you any figures. So this is just to emphasize the importance of more evidence needed concerning how much WASH is actually contributing to the AMR burden. And from history, again, if you look at the Ugandan context, studies concerning AMR have mainly been, clinical and at a hospital setting, which of course has shown over the years an increase in resistance developing against various microorganisms. But how much that is being contributed to by environmental and WASH is still a big gap which we need to address. And also to emphasize that one good thing that I'm happy to share is that in the Ugandan context, the Ministry of Water and Environment is currently developing a framework to help with the surveillance of AMR in the environment, which we hope when that is finally available and up and running, it will really be instrumental in carrying out more research, but also generating more evidence and more statistics to actually show how much the problem is being contributed to by environmental health. And that I think would be instrumental for us to put in place very clear-cut measures that would help reduce on the problem, but also clearly have environmental health and WASH make a very clear contribution to the discussion and to the AMR burden that we are facing. Thanks, Tracy.
Thanks, David. And that's really positive news. And I can see Nick smiling at that idea. And I imagine that Kate is smiling as well at the idea that Uganda are taking that seriously, and look forward to hopefully learning from how they do that. Because I think, as we've all experienced in like Uganda and Malawi, often the policies and elements like that look fantastic. And then the implementation is the tough part of people like yourself at the coalface. So I hope that they will give the equal support to trying to do that. And I look forward to following how that goes. Kind of staying with Uganda, Lawrence, I wonder if I could come to you to maybe give the kind of wider animal perspective that you see there. I know that there's a lot of challenges, obviously, within that element of One Health, and Derek touched upon the kind of high antibiotic consumption in those groupings, but also the challenges that you have between, you know, the urban and rural animal management and kind of free range farming, shall we say, that goes on in a lot of areas. Do you want to give us some of your thoughts and insights?
Okay, thank you so much. Just to add to what my colleagues have already mentioned, and from the preliminary session and also from the results, it revealed that the animals are part of the household and part of the communities. They share the household, they live in the same house, they share the rooms. And importantly to note is that the communities do not consider the poo or the feces to be more disgusting compared to the human poo. So they are able to comfortably stay with animal poo other than human beings. And also we need to note that in humans, we also have sewage systems, at least also toilet systems. But for the animals, it is within the same household, same compound, same environment, which is their place of convenience. So when you look at the contribution of MMR from the animal perspective, it is still very neglected, because there is limited surveillance, there is limited research going on to really understand and appreciate the role of animals toward the contribution of MMR. And we need to recognize, apart from living with animals, they also end up on our plates. From the environment, from the household, from sharing the resources, most of the products also end up on our plates. We need also to think what is the role of humans towards the development of MMR in animals, which reversely comes back to humans. I think there is almost no study or limited study trying to look at the role of humans towards the development of MMR in animals, and then from animals back to humans. Currently, we are focusing so much on heavy misuse of antimicrobials in animals. Yes, it is very, very true that in animals, the regulation and the use of antimicrobials is very, very low. We are still having a very, very big gap. And when it comes to infection prevention and control, in terms of animals, it is also still very low. So all those factors brought together, they bring animals at the center of MMR. Whereas there are lots of initiatives, including tripartite agreements, but when it comes to the real resource allocation and focus in terms of investigating and surveying the MMR in animals, it is still very limited. And remember, sometimes you cannot even differentiate the rural from urban, because sometimes the practices are almost the same. The way we keep animals in the rural areas and in the urban areas sometimes is almost the same. Probably the difference would be on the numbers and the confinement for some of the animals. But when we talk about animals, it is also important to know that we are not talking about cattle alone. We are talking about a range of different animal species, poultry, piggery, goats, cattle. Sometimes when we talk about animals, people think we are talking about cattle. No, we are talking about a whole range of different animals that in one way or another are living within the household and communities, but also get diseases and they need treatment. When they fall sick, unfortunately, we don't go to the hospitals. The communities and our households are still the same hospitals. So there is a very big problem that is compounded that needs to be unpacked. And I think that is what DRAM is bringing on board, trying to use this One Health approach, and to the data that we have generated is still limited, and we still need more data. For now, I can leave it at that level. Thank you.
Thanks, Lawrence. And I think you raise a really important point there that we've seen certainly in Drum and Malawi, and I think Uganda as well, where households are holding on to antibiotics and using them either for the animals or the family, depending on who falls sick as well. So there's like multiple uses for them being held at household level. And I think you raised an important point there as well, which I'm going to follow Amy's suit and give a bit of a plug, where you talked about the food on the plate. And part of the drum study too looked at the wider environment. So we also have another presentation tomorrow in the verbal presentations, our colleague Mindy Panola, who has been sampling through the markets in Malawi. So if you're interested to see what that environmental contamination looked like, we'd welcome you to go and join that as well. So Joe, we've talked a lot about the wider environment, and Derek talked about the focus of drum on the household. And I know through the plenaries and some of the side events this week, we've been talking about that kind of sometimes that dichotomy between, should we be targeting households? Should we be looking at the wider community? I'd really like to have your thoughts on where you think we should prioritize, or can we choose to prioritize? Do we have to move both things along together to make some progress here?
So thanks very much, Tracy, and thanks to everybody. Lots of great points being raised. I mean, I think this is a collective action problem, and in some ways, it feels right now like early climate change conversations where we didn't have like our arguments for the role of the environment in controlling AMR, and also a lot of our other arguments about control measures feel very conceptual. We don't have a lot of primary data, not a lot of good evidence. And it also is something whose effects will be felt so diffusely at scale. So it's like a difficult thing to get your hands around and start to prioritize actions when the effects are so diffuse. But no, look, I think we really need to focus on systems here. And this is a place where I think we can draw on some of the other themes that are emerging in the global WASH space around the need for collective action and the need for organizing ourselves to implement change at scale. Because if we know anything about AMR, it's that it's sort of like the, injustice, an injustice somewhere is an injustice everywhere. I mean, AMR that breaks through in one place is everywhere. I mean, we're all globally connected now. So I think it's important to think about AMR control in that respect, that, it's about the emergence of hotspots, which can, and the emergence of AMR, which can happen at very, very localized scales. But that can quickly spread, to scale very easily. So I think we should think about it in that way. And I think that also raises a lot of important challenges for us in terms of how we organize ourselves. I don't think there are any easy answers here, but it is a collective action problem, I believe.
Yeah, I think absolutely dealing with these kind of wicked and complex problems is going to be incredibly difficult. And I'll come on to maybe coming back to the group with a question around that, some of the challenges around that in a moment. But I'm conscious that for once, for Nick's life, the clinician is the last to speak. So I just wanted to go back to you, Nick, and sort of say, look, we've talked a lot here about the WASH perspectives and a lot about the environment. But how important do you think the kind of antibiotic use story still is? Is that something that we need to kind of get over because it's there now? We have AMR in the environment and now we need to just focus on dealing with that containment, or do we still need a really strong narrative and to be addressing this antibiotic use part as well?
Thanks, Tracy. I think we do need to be addressing the antibiotic part of the piece very strongly, but I think we need to put a positive spin on it and make it about getting the right treatment to the right patients. I work at a hospital in Malawi, and there is still a massive burden of severe bacterial infection, and any antibiotic usage policy, any antimicrobial stewardship action needs to take into account that there's an urgent need for people to receive timely antibiotics to treat severe bacterial infection. So I think the key to antimicrobial stewardship is starting with prioritizing nobody dying from a policy barring access to potentially life-saving agents, particularly in a context where diagnostics are frequently in limited supply. So I think we can make a strong case for improving how we use antibiotics, starting off with the patient coming through the front door. And I think the story about antibiotic misuse does need to be tempered somewhat, because antibiotic usage does promote antimicrobial resistance. So even the best use of antibiotics will lead to acquisition of antimicrobial resistant bacteria if it's done in an unsafe environment. And I think in this regard, antimicrobial resistance isn't just a property of a bacteria causing an infection which might kill someone. It's also a marker of failure in quality of infrastructure. And whether that's in hospital, where it's a marker of failure of healthcare quality, or whether it's in the community where it's we can see in Drum, it's a marker of failure of WASH infrastructure. It does point to more than just a patient level problem. So yes, we need to improve how we use antibiotics and how they are policed, but whilst respecting the fact that the first requirement is to do no harm and to try and do your best to save lives. And I think it's where I'd like to build on what Kate was saying and bring it back to the first point. I think the a really good policy around antimicrobial resistance is important, but you touched yourself on the importance of it then being adequately prioritized in terms of policy implementation. And I've heard colleagues at the Ministry of Health in Malawi complain about the lack of resources available to implement excellent national action plans. And there's not an easy solution there. As Joe has said, it's an incredibly complex problem requiring multi-sectoral response.
And once again, you've brought me naturally to a perfect segue, Nick, thank you. Because Derek presented, and you've all spoken about this in one way or another, about this kind of One Health approach to addressing AMR, but we've also all spoken about how complex that approach is and how challenging it can be in terms of the need to work in an interdisciplinary or transdisciplinary way in order to really tackle that. I think in the plenary before this session, there was some excellent discussions around positioning of the WASH sector, our environmental health, and also about humility, about understanding what the limitations are of what we can achieve as an environmental health or WASH sector as well. So I wonder if we could have a kind of more of a group discussion around the challenges that we might face with this attempt to work in a One Health way across different sectors. Kate, if I could come back to you in the first instance, just with your experiences of seeing how that's operated in other countries where maybe it has worked, if you've got examples of where it's maybe had successes in the past, and then perhaps come on to the team again in Uganda about experiences that the challenges and positive opportunities that they see as well.
Yeah, well, so certainly, as I've mentioned, the national action plans on AMR are certainly, you know, the attempt to kind of to bring that One Health thinking into like a sort of a concrete, actionable thing. And you know, One Health has been around as a concept for quite a long time, but certainly COVID has really elevated its visibility within WHO. There's big kind of working groups trying to figure this out, particularly, you know, thinking from the perspective of emerging zoonotic diseases, but I think also kind of more broadly. And maybe some of you on the panel are more up with it than I am, but my feeling is we haven't really cracked it at all, actually. You know, it's very difficult to disagree with One Health conceptually, but it's equally difficult to ground it in something really practical that acknowledges the complexities and time associated with that coordination and collaboration. So I think, at least in what I'm doing, I'm really trying to focus on those things that have really clear intersectionality. And, you know, one obvious one is something like, you know, safe use of wastewater in agriculture. That's clearly a One Health problem. Other bits like washing healthcare facilities, not so much, you know. So we need to kind of be a bit disciplined about that, I think. Now, obviously, surveillance is another one, and the research agenda is really clearly within that One Health space. But yeah, I'm kind of itching to get a bit closer to something kind of more actionable. I'm just, sorry, while I'm speaking, I wanted to kind of go back on this point before, because lots of people were talking about kind of attribution to different sectors, and within the One Health approach or anything else, I'm coming to the conclusion that yes, attribution is important scientifically, but it can have this kind of unhelpful kind of side effect of saying like, oh, well, we don't really need to do anything because the big problem is with manufacturing, or we shouldn't do anything because the big, you know, the big problem is over there in agriculture. Where I think what we need to kind of acknowledge is that there are practical things that can be done in every sector, and that while attribution is kind of important scientifically, it shouldn't be a barrier to actually getting on with what we can do to kind of address this urgent problem. I'll stop there. Thank you.
I think that's a perfect I'm just gonna in some ways that would be the perfect way to finish off the panel, Kate. We should have kept you there for that one, but I think that's absolutely the right bit, that kind of idea of lots of marginal gains from lots of you know, opportunities and things that we can do now. David, I don't know if you want to just give a very short perspective from Uganda, what your hopes are in terms of AMR control as Uganda moves forward with its national action plan as well, before I round up.
Thanks, Tracy. I think from the Ugandan side, it is important for us to continue harnessing the One Health approach. And as you asked earlier, we are doing fairly well in terms of working together across various disciplines. So for example, at national level, we have several committees and you know, structures that support working together, but also lower down at district level, we are seeing that coming through quite well. Again, several challenges exist, including some of the ministries and departments still having to do planning individually, but also their budgeting structures not necessarily permitting, you know, the cross working together between, you know, ministries and disciplines. So that is actually still a challenge. But also finding some people, professionals who are traditionally, you know, quite used to working in their own silos without necessarily, you know, appreciating the One Health approach. And at Makerere University, we've tried to target that by, in our training, having the One Health approach introduced early to the students in various disciplines, whether from human health, animal health, and the environment. And that, I think, has really enabled the graduates appreciate One Health a bit better, which we are seeing come through quite well in their practice. But on the other side, I believe concerning WASH and AMR, besides having the structures and the frameworks to support more evidence generation, I believe there's one particular area that we could also provide some more insights on, and that is how well waste is managed at household levels. In our recent study, we actually found that most of the unused antimicrobials and related antibiotics are actually disposed of together with general waste. And that is, I think, a neglected area we've not done a lot on. I think a lot of emphasis in WASH has been, you know, hand washing and water coverage and sanitation improvement. But I think there's an opportunity for us to really see how well antimicrobials are disposed of. And I think that would really be instrumental in terms of reducing on the AMR occurrence. And just to end by saying that in a recently published commentary that myself, Tracy, Kondwan, and a few others were able to work on, we really emphasize the three main pillars regarding environmental health and AMR. Of course, the first being WASH, which we are discussing a lot. The second being food hygiene and safety, which relates both to animal products, but also plant products. And my colleague, Professor Mugisha, has talked a bit about the animal products. But the third is really concerning waste management. And that's the one, as I said, I believe we've not done a lot on, and there's an opportunity for us to invest some more effort and energies moving forward. Thanks, Tracy.
Thanks, David. And thanks for bringing us to a perfect kind of close. Apologies that I am kind of rushing towards the end here. I'm conscious that Manal is breathing down my neck to not be the session that finishes late out of the whole conference. So I just want to round off with a couple of shameless plugs. We did have a couple of posters presented in the last couple of days around work on drum as well, within markets with ESBL methods with David, and also on our transect walks using the Sanipath method for ESBL as well. So take time to look at those, as well as Mindy's presentation tomorrow. tomorrow. Don't forget Amy's colleagues' presentation as well. It's great to see AMR getting more discussion within UNC conference. I want to say a huge thank you to all the panelists. Sorry that we have not heard as much from all of you as we would have liked, but it was really great to be able to hear all of your different opinions from the different disciplines and perspectives. A particular thanks to Derek and Kondwani, who pulled this session together, and hope that it's been insightful and that you have all enjoyed it. They've done a fantastic job. And again, to the sponsors and to the fantastic research teams that we have all worked with in Drum across both Malawi and Uganda, who've contributed to some of the work that's presented today. So yeah, keep in touch about AMR with all of us. I know we'll see more and more, and we look forward to seeing you in the other sessions. Thank you.